So good afternoon. Nice to see few people. So probably yeah, but this is still YouTube also, I guess. It's online, so it's still hybrid. It's not a nice situation to be between the devil and the deep sea. But as clinicians, we are very often positioned into this predicament. And the clinical decision always hangs like a sword of Damocles on the head, and you need to sift through all this entire spectrum of the conundrums of, I would say, the different um, differential diagnosis between all those manifestations, and then you need to come to a decision. So I guess the bottom line is that we don't give up on our patients. So we do these exercises and we are happy about it. Sometimes they're happy endings, sometimes they are not, but we always hope that they would be happy. So today's would be another sojourn and exercise through one such case that from the Department of Neurology we will be presenting in the combined clinical round. This is the case which has been managed by the Unit 3 in the Department of Neurology. So I would now request Dr. Jerry, our DM student, to present the case, and then as the case would be discussed in detail, ultimately the discussion as well as any questions thereof will be handled by all of us, specifically the consultant who's managed the case, Dr. Ayush Agarwal. So, Jerry.
Thank you, ma'am. So, respected faculty and dear colleagues, this is the clinical combined rounds from the Department of Neurology, and my name is Dr. Jerry George, Senior Resident, Neurology. So, let me tell you the story of a patient who got stuck in between the devils and the deep sea. So, I have divided this into two parts. Part 1 happens in 2019. His story starts in 2019. So he's a 31-year-old tailor from Bihar. He was referred from AIIMS Patna to IRCH in view of a mediastinal mass. So what happened? Outside the IRCH OPD, he becomes dyspneic and he gets admitted immediately and he gets intubated in the ward. So this was in January 2019. So on further probing, he was symptomatic since 45 days. There was insidious onset neck weakness, proximal upper arm lower limb weakness, and left eye ptosis. And also for 4 days, he was having respiratory and swallowing difficulty also. There was also history of diurnal fluctuations. So on examination, the patient was intubated. There was bilateral lateral rectus palsy, left ptosis, and bifacial weakness with a flexor, neck flexor weak, and there was symmetrical proximal limb weakness. And his anti-AChR antibody turned out to be positive. So we made a diagnosis of generalized myasthenia gravis in myasthenic crisis. He received 3 cycles of plasmapheresis in IRCH and he was transferred to neurology. There he received 5 more cycles of plasmapheresis. He improved and he was weaned off. And by this time, we have done a mediastinal biopsy also, which was suggestive of thymoma. And he was planned for elective surgery. He was discharged on symptomatic treatment, pyridostigmine, prednisolone, and weight-based azathioprine. Now the mediastinal mass management it was planned from their side for surgery was planned for June 2020, but it was deferred due to the COVID lockdown. So now what happened? Now we enter the part 2 of this conundrum. That is in 2021. The patient presented to AIIMS emergency with bilateral tonic-clonic seizures 2 to 3 per day since 2 weeks, and also unknown onset bilateral tonic-clonic seizures since morning on day of presentation without regaining consciousness in altered sensorium. And he became COVID positive. This was in June 2021. So he was at that time we had the dedicated trauma COVID center as trauma center. So we transferred the patient to there. And at that time, I was posted there in the ICU ground floor where this patient was transferred. My shift was at 9 p.m. to 3 a.m. and I saw this patient around 9:30, 10 p.m. So when I saw this patient, the patient was E4V phasic M5. So there was difficulty in examining the patient because we were in level 3 PP. But anyway, he was loaded because of the seizures in emergency because with levetiracetam. But in view of persistent altered sensorium, and we made a clinical diagnosis of non-convulsive status epilepticus because we didn't have a provision of EEG at that time there. It was difficult, so we had to go with our clinical acumen. So we intubated the patient and started on midazolam infusion. So let's rewind. What happened till now? In 2019, the patient had a myasthenic crisis. 2020, he was maintained on weight-based azathioprine, doing good. May 2021, he presents with seizures, and in June, he lands up in non-convulsive status epilepticus. Now the question arises: a patient with myasthenia gravis, well maintained on azathioprine, why would he present in status epilepticus? So we got the baseline investigations done. Not much of a contribution to the diagnosis, but platelet was low and the procal was borderline, CRP was raised, ferritin was raised, the cultures were sterile. So waiting MRI in trauma center, we got a CT done. And to discuss the CT, I invite Dr. Shairi, Senior Resident, Neuroradiology.
Thank you, Dr. Jerry. Good afternoon, dear faculty and colleagues. So this is the non-contrast CT of the patient on the day 2 of the presentation. What we are seeing here is a confluent white matter hypodensity. This hypodensity involving the cortical, subcortical, and the deep white matter in the frontal lobe, in the temporal lobe, involving the medial temporal lobe as well. It's asymmetric and it is involving the bilateral hemispheres more on the left side. We can spot the hypodensity in the left side in the around the region of the insula, here in the region of the parietal lobes, and involving the medial right medial temporal lobe as well. Hypodensities are also seen in the orbitofrontal gyrus and the cingulate gyrus here. So contrast was administered in this patient, and this is the contrast enhanced CT where we are seeing these hypodensities. There is no appreciable contrast enhancement. We did not spot any discrete lesion in this patient, and we can see that there is sparing of the basal ganglion. The hypodensities are involving the temporal lobes, asymmetric bilateral temporal lobes, and sparing the basal ganglion. Based on these imaging findings, our differentials was HSV, herpes encephalitis, and second was autoimmune encephalitis, given the pattern of the involvement of the disease.
Thank you, Shairi. I'll take over. So once the CT and CT was done, meanwhile, we did the CSF and we had sent for pan-viral PCR because we had HSV encephalitis high on our list and the cultures were awaited. And we had also sent serum autoimmune and paraneoplastic profile. So routines of the CSF were normal otherwise. So meanwhile, when we were doing all these things, patient's seizure was not controlled. Actually, he had this focal twitching that was coming in between, and we had to titrate up the midazolam, and still it was not controlled, and we had to add propofol also. And he was also on broad spectrum antibiotics, and obviously we were thinking of HSV, and the dictum is that if HSV is a differential diagnosis, we have to start acyclovir. So we had put him on acyclovir also. And azathioprine and prednisolone were stopped. So where are we? Could it be an infective cause because the patient was on azathioprine, immunosuppressed? Could it be HSV encephalitis? Could it be an opportunistic infection? The patient has an autoimmune disease in the background. So could it be autoimmune encephalitis? Or the patient has a thymoma. So could it be a paraneoplastic encephalitis? So we went for the MRI and Dr. Shairi.
This is the axial flare where we are seeing the cortical, subcortical hyperintensity involving the left frontal temporal region. Asymmetric hyperintensities are also seen in involving the left insula and the left side of the and the bilateral medial temporal lobes are also involved, and patchy hyperintensities are also seen in the right parietal cortex. and the cingulate gyres, bilateral cingulate gyres can be seen involved. And we can again note that there is sparing of the bilateral basal ganglion. So on this is the T1 weighted image where we are seeing there is a hyper intensity involving the cortex in the left temporal lobe, which is suggestive of cortical laminar necrosis. This is the susceptibility weighted image. We did not spot any blooming in any of the uh, planes or in any of the slides, so there was no hemorrhagic or calcification. This is the diffusion weighted image where we have a DWI and the corresponding ADC maps. The lesions, the areas are hyper intense on DWI as well as on ADC. So there is no true diffusion restriction. This is T2 shine through only. So there is no susceptibility blooming. There is no diffusion restriction. And on contrast, I mean, there was some patchy enhancement in the left temporal lobe. This is the CCT of the chest where we can see homogeneously enhancing mass lesion located in the anterior mediastinum. On the sagittal image, you can see an elongated mass located in the retrosternal region. This lesion was seen invading the superior vena cava on the right side. You can spot here. So, given this is the suggesting the invasive nature of this pathology. So based on these findings, our possibility, our first diagnosis was HSV encephalitis again because of the involvement, because of the pattern of involvement involving the bilateral medial temporal lobes. Uh, and sparing of the basal ganglia, and the cortical laminar necrosis that is seen on T1 weighted image is seen on the HSV encephalitis. The second possibility that was there was autoimmune encephalitis. There is a lot of overlap as far as imaging is concerned when it comes to differentiating HSV and autoimmune encephalitis. A lot of overlaps, but there are some imaging features that are prevalent in one group than the other. Most importantly is the diffusion restriction. In at least 50 to 60% of the cases, they say that diffusion restriction is commonly seen in HSV encephalitis than in autoimmune encephalitis. And the pattern of involvement, they say it is the the autoimmune encephalitis involves the basal ganglia, and the extralimbic involvement is more common as compared to HSV encephalitis, which remains mostly localized to the temporal lobes. Then there is the hemorrhagic changes on the susceptibility weighted images. They are more common seen in HSV encephalitis as compared to autoimmune encephalitis. So there is an overlap, but and then in our case, given the history of neoplasm in the chest, autoimmune encephalitis is a possibility. So our differentials would be HSV encephalitis first and autoimmune encephalitis second. And this is the chest lung window where we didn't see any of the pathology, no ground glass opacities, because this patient had was detected COVID positive. So there are no sequelae or any findings that would suggest the involvement of the lung by the COVID.
Thank you, Sharik. So the patient is between myasthenic crisis, thymoma on one side, and COVID and encephalitis on the other side. So what do we do? There was no improvement despite acyclovir. So by this time, we already had sent this autoimmune and paraneoplastic panel, and these are the list of that panel antibodies that is tested: NMDA VGKC, Casper LGA1, AMPA, GABA, AB, and ampifycin CB2, anti-MA, Ta, and Re-Yo-Hu, GAD, Titin, Recoverin, SOX1, SIG4, and TR. And the CSF pan-viral PCR came out to be negative. And we got anti-Titin positive. So we decided to go ahead with IVIG and MPS. IVIG was given at a dose of 2 gram per kilogram, total dose divided over 5 days, along with MPS pulse for 5 days. So he was on acyclovir levetiracetam, phenytoin, antibiotics, MPS pulse, and IVIG. So the IVIG course was completed. By this time, the seizures got completely controlled. The patient's sensorium improved to E3VT M6 drowsy, and propofol was earlier itself stopped at 48 hours. Midazolam also we could taper and stop. And because of the prolonged intubation, we had to do a tracheostomy. So patient weaned off to room air, and within the next 3 days, we got the patient as E4VT-M6. At that time, during the COVID times, we used to lose some patients, but sometimes these patients got better. It was a feel good situation, and he became RT-PCR negative, and he was transferred to main AIIMS. And the patient was under neurology, and he was planned for thymectomy. Now, Dr. Naveen, Assistant Professor from Surgical Oncology, I welcome.
Thank you, Dr. Jairi. So this patient was taken for the surgery, and since it was a locally advanced thymoma involving the great vessels like SVC and abutting the pericardium or query infiltration of the pericardium. So this patient was taken in CTVS OT with the help of CTVS team, and patient was planned in general anesthesia with head and neck extension position. So the median sternotomy was done, and the patient had almost 10 into 8 centimeter mass, which was involving the almost entire thymus with infiltration of the pericardium, right phrenic nerve, and azygous vein. The mass was also encasing the almost entire length of the left brachiocephalic vein and the anterior wall of the SVC, and simultaneously it was also involving the upper apical segment of the right upper lobe of lung. So the left phrenic nerve and azygous veins were ligated, and the tumor was taken out with the total thymectomy, with the taking the partial pericardium, the almost entire length of left brachiocephalic vein, the anterior wall of the SVC, and the vasoresection of the lung. So patient was taken cavoatrial bypass before resecting the SVC to maintain the blood flow from SVC to atrium, and the SVC was repaired with the pericardium, and ICD was placed, and patient was shifted into ICU. The patient was kept on inotropes and stopped on day 1. Patient shifted and ward on day 1. Started orally on day 2. We did not find any major events, and the ICDs were taken out on day 5, and patient was discharged on day 6. Pathology, I would like to invite pathology.
Thank you, sir. Um, we received 3 specimens from the surgical team. One was a thymectomy specimen, other one was a partially resected superior vena cava and a brachiocephalic vein. And grossly, the thymectomy specimen weighed around 80 grams and it was measuring 9 into 8 into 2.3 centimeter. And on cut section, it showed a fleshy tumor with areas of cystic degeneration. And we took random sections, and on microscopy, these were the sections. It showed a tumor which is very much lobulated, and we can see there are nodules of cellular tumor along with which are separated by thick fibrous septae. So it was a very lobulated tumor. Here, this is one more higher power image where we can appreciate the cellular nodule with surrounding fibrous septa. And coming on to higher power image of the same, the cellular nodules are composed of large polygonal neoplastic thymic epithelial cells along with some moderate amount of dispersed lymphocytes or thymocytes. And this is a cytokeratin stain which highlights the thymic epithelial cells. So we can see the thymic epithelial cells are highlighted here, and we can see the thymocytes or the lymphocytes which are negative. So based on the IHC profile and this thing, we gave a diagnosis of B2 thymoma. And the other 2 specimens which were labeled as brachiocephalic vein and the superior vena cava also showed infiltration by a similar tumor.
Thank you, Dr. Sanjay. So the patient on last OPD follow-up was in last month, October 2022. MRS is 0. Steroids, acetylcholinesterase inhibitors tapered and stopped. He is only on azathioprine, 150 mg. So the final diagnosis is generalized myasthenia gravis in crisis, thymoma with paraneoplastic encephalitis, COVID positive. So a short review. Studies have shown that up to 3% of people with myasthenia can have epilepsy, but there are no proven associations. And this was a study conducted in Spain. This was a retrospective analysis of 20 years cases. 43 patients with thymoma and encephalitis were looked upon. And upon looking upon the clinical profiles of this paraneoplastic encephalitis, the most common antibody was GABA A receptor, and second most common was AMPA. And sometimes, many a times, there was no antibody seen. So, what is the importance of anti-titin antibodies, which was positive in our case? So, it's a giant protein which is seen in the sarcomere and essential role in the muscle elasticity. It was first discovered in the serum of myasthenia gravis patients in 1990. The importance is that it is closely associated with the presence of thymoma, and anti-titin antibodies are detected in up to 90% of thymoma with myasthenia gravis. So why we made a diagnosis of paraneoplastic encephalitis? In this case, anti-titin positivity, the myasthenia is associated probably with the thymoma, which was proven histopathologically also. And all the autoimmune profile was negative, and yet the MRI signature of an autoimmune encephalitis. As it was associated with thymoma, we made a final diagnosis of paraneoplastic encephalitis. So we had published this case in the C-Sharp journal also. Thank you for listening, and special thanks to whole neurology team, neuroradiology and surgical oncology team, pathology team, and COVID trauma center team. Thank you.
Thank you, Jerry, for your elaborate presentation. If there are any questions, please.
Possibilities and probabilities.
Sir, since we don't have a marker for thymomatous encephalitis per se, so we can never be sure that it is a definitive paraneoplastic encephalitis. But in the background of the presence of a malignancy and these manifestations, we can say that it was a probable paraneoplastic encephalitis. A recent study published on paraneoplastic encephalitis therefore has brought out a scoring system where if there is a presence of a malignancy, you directly get +3 for that, because newer antibodies are being diagnosed by assays by the day. So they say that in the presence of a malignancy, if somebody has manifestations to suggest an autoimmune encephalitis, we can definitely call them a probable paraneoplastic encephalitis.
Thank you. Yeah, this is a big problem we also face sometimes. You have dermatosis that are paraneoplastic, but can also occur in the setting of not having neoplasia.
I was wondering whether a repeat neuroimaging was done subsequently, and if so.
We did not do a repeat neuroimaging because the patient was otherwise absolutely fine. So we did not suspect anything to be left behind. More so, we can do that. So the patient is from Bihar and he comes with great difficulty.
I was wondering whether these changes they would have reversed. So that was like,
that's a great suggestion. We'll definitely do that. Thank you.
How confident are you that it is the titin is the one which is the causative or something else?
We're not saying that titin was the antibody which is responsible as the paraneoplastic antibody. It was just something that gave us a lot of confidence that we were dealing with a malignant neoplasm, because up to 95% people who have titin positive have a higher risk of developing a thymoma. So that is something that gave us confidence to look towards paraneoplastic, and also all other infectious workup was negative as well as autoimmune. So based on all of that evidence, we tended to move towards a diagnosis of paraneoplastic. Thank you. I hand over the floor to Neurosurgery team for the next presentation.
So good afternoon, everybody. So till the presentation loads, I'll give a brief introduction of what the today's CCR is about. So this is about development of a very new minimally invasive technique. It's practically a bloodless technique for the most maximally invasive pathology, which is a complete disconnection of an hemisphere. So if you look at history, hemispherotomy was first performed by Walter Dandy somewhere I think in 1960s or 1950s for a patient with malignant glioma of one hemisphere. And इसको open कर दीजिए. Unfortunately, the GBM recurred within 9 months and the patient died. But this was an experiment to show that a person could survive with just one hemisphere. And later on, it became removing one whole of hemisphere became a very it became a very esoteric surgery, especially for people who are suffering from hemispheric epilepsy. So where the whole hemisphere is involved because of seizures and the whole hemisphere had to be resected. And that is how hemispherectomy was born, where you would anatomically remove the whole hemisphere. And surprisingly, these patients did very well. They developed, even the weakness improved, they got amalgamated in life, they were even bilingual, they did very well in college. And it was given up. The reason it was given up is because of a dreaded complication which happened in approximately 5% of the patients. And this was called as hemosiderosis, and which was a fatal complication. They had a progressive cognitive dysfunction. And this then developed into a hemispherotomy where we would still do a craniotomy and then disconnect the hemisphere. So the disconnected hemisphere would lie there inside, would not be physically removed, but because it's electrically disconnected from rest of the brain, the patient would be seizure free. So that was the birth of hemispherotomy. So we show that how we have developed from All India Institute, Department of Neurosurgery, something much more innovative, which has now been taken over by various centers across the world. And it was, you can say this technique is completely made in India. So at the outset, I will request Nihal to come and present the clinical history.
Good afternoon, everybody. I'm Dr. Nihal. I'm a fellow in epilepsy surgery. So today I'll be presenting a case of right hemispheric atrophy. Patient is a 21-year-old female. She had stroke at the age of 5 years. The exact details of the etiology are not known. She had developed right MCA infarct. And post infarct, after 6 months, she started developing seizures. So the onset of seizure, age of seizure onset was 5.5 years. So she is now 21 years. Total duration of seizure is 16 years, and frequency of seizure is 2 to 3 per day. Perinatally, there is no history of any birth asphyxia, there was no febrile seizures or no other head injury. There were up till the age of 5 years when she developed strokes, there was a normal developmental milestones achieved. So post this, she was on aspirin for stroke prophylaxis 75 mg HS and on 4 anti-epileptic drugs over the course of time. Tablet levetiracetam 750 gram BD, Cloba 25 mg, oxcarbazepine 600 BD, and phenobarbital 60 mg, 120 mg HS. On examination, she had a grade 1 spasticity, and upper limb was 4 minus. Power of the upper limbs, left upper limb and left lower limb was 4 minus by 5. Right side was normal. Hand grip on left side was 20%. The pincer grasp was absent. Fine touch was decreased on the left side. She had left UMN 7th palsy. On neuropsychology assessment, verbal learning and memory was intact, whereas the visuospatial memory, visuoconstructive ability, memory, this is mostly indicative of a right side pathology that was impaired. So I'll call upon Dr. Manjari Tripathi to talk about semiology and video EEG.
She was a young girl bought by her parents, and the function of the video EG and the neurologist is in the team is to first tell if they are seizures, yes, so are these episodes seizures, and second is if they are seizures, where are they coming from? Are they concordant with the imaging finding or discordant with the imaging finding? So she had several events. She had 7 events during her monitoring, and as you can see here, she's talking to her mother. And her left hand, you have to She's unresponsive, unable to show her tongue, has intermittent clonic jerks of the left upper limb, still unresponsive, still unresponsive. Now she turns to look through the wall, and now she is responsive. So the events were another event. So again, the same left upper limb clonic, during which she is unresponsive. So definitely they were seizure events, and they were focal seizures with impaired awareness. How can I escape this? So they were refractory. She was on 4 drugs, and her interictal EEGs, as you can see here, the bipolar montage, right 4, left 4. You can see this polyspiky activity, which is, predominantly frontocentral, not so much in the occipital. And on the right, on the right, yes. And there are phase reversals. You can see a nice phase reversal with a polarity at F8, that is either posterior frontal or anterior temporal, which is seen in the interictal EEG. And the phase reversals are not only seen at F8, they are also seen at F4, indicating 2 possible foci, probably mid-frontal or posterior frontal or anterior temporal. Ictal onsets are characterized by repetitive sharps, low amplitude, which progress further to sharpish, polymorphic sharpish activity towards the end of the epoch with repetitive spikes, confirming that these are indeed ictal events as we were suspecting. So definitely amplitudes and origin seems to be the right hemisphere, predominantly frontal and frontotemporal, less likely in the occipital electrodes. So this was our localization on the video EEG. This I'll hand over to the neuroradiology team.
So on imaging, MRI revealed gliotic changes entirely in the right hemisphere. As you can see, there is ex vacuo dilatation of ventricle. There is brain atrophy on the right side, right hemispheric. And except for the basifrontal and some rest, every parietal, occipital, and temporal lobe, there is extensive gliosis. As you can see, there is a gross atrophy, hemiatrophy of the right side with the dilatation of ventricles. So, a diagnosis of right hemispheric pathology was obtained from this MRI study. So, for the interest of time, I'm not going to go back to all the sequences. Syscos, this syscos is basically subtraction of the ictal spect with the co-registered with the interictal spect. So on spec we had probably the pathology was localized to the left side, but it is maybe due to the atrophy on the right hemisphere. The seizure spread usually we see that in many cases of syscos the localization will be onto the contralateral. So MEG revealed uh, there are three to four types of localization. There was right temporal, right parietal, as you can see. In this, this is a magnetoencephalography in which the right side is it's actually the left. There is a side reversal. So almost all the pathology is on the right parietal, right frontal, right occipital. So which is concordant with our diagnosis of right hemispheric atrophy. So based on this imaging findings and on the discussion on our epilepsy surgery meet, we plan to go ahead with the hemispherotomy and with the robotic assisted thermocognitive hemispherotomy ROCH, which Ramesh sir is going to talk about the further planning.
Good afternoon, everybody. So we planned in this patient robotic guided hemispherotomy, which is a new technique described from our own institute, and Professor Chandra is a pioneer in this technique. So we have been doing this technique for hemispherotomy, where we use, it's called as a bloodless hemispherotomy technique, and we use radiofrequency ablation for this to disconnect the whole hemisphere without actually opening the skull. I'll be just briefly going through the planning. So we plan this in 5 steps where we disconnect the hemisphere. Basically, the corpus callosum is the one which is a major disconnection which connects 2 hemispheres. Once the corpus callosum is disconnected, then the anterior frontal efferents and the basifrontal efferents are the ones. That is the anterior disconnection. Then the middle disconnection, which is basically it disconnects the middle of the hemisphere. That is, we keep the basal ganglia as well as the thalamus, that's the diencephalic structures intact, and we go lateral to the diencephalic structures and then we disconnect the whole of the hemisphere. And then finally PDC and amygdala, which I will be discussing subsequently. So this is a corpus callosal disconnection. Generally we require 4 trajectories, but in this, because it was a post-infarct case, so you can see here, this is the whole of the corpus callosum, and then we take, in this patient we had to take 3 trajectories, one from here, then the anterior and the basal disconnection, which disconnects the frontal efferents from the rest of the hemisphere. And then this is the splenium. From the splenium we disconnect, that is the posterior disconnection. In this, these are the corpus callosal trajectories. We made 3 trajectories, as I already told. This is the splenial disconnection. This is the body and the genu of the corpus callosum. Then comes the ADC, that is the anterior disconnection. Anterior disconnection involves disconnecting the frontal efferents from the unilateral frontal efferents from the other side of the hemisphere, where we take the whole burning point till the base of the bone. Again, anterior disconnection. We use 3 trajectories for the anterior disconnection. Then comes the posterior disconnection. The posterior disconnection involves disconnecting the temporal efferents as well as the fornix. The hippocampus turns posteriorly into the lateral ventricle as a fornix. So we disconnect it. This is a transventricular trajectory. This is, we generally perform it last, because once we enter the ventricle, there will be a CSF leakage and then the brain shift happens. And we will be doing this stereotactically. So that is the reason we do it last. After this, this is the middle disconnection. The middle disconnection is usually among the, takes a lot of time, apart from the other ones, because it has to cover all the brain from here till here. So if you consider this as a thalamus, thalamus, and then the basal ganglia. This is the caudate nucleus. So we generally disconnect, the line of disconnection goes lateral to this, so that we preserve the diencavity structures and the patient's sensorium is preserved. Again, these are the middle disconnection. So, and then comes the amygdala. Basically, we have to disconnect the most epileptogenic structures like amygdala, and then hippocampus is here. We do the hippocampal trajectories as well. So once the planning is done, this planning is done quite well before the surgery. We plan it approximately a couple of days before the surgery, and this is how it looks like. So these are all the trajectories. And then initially we started with normally burning the trajectories. Then Dr. Chandra gave us an idea that why not we do a X technique, where we can actually, because it's a 3-dimensional structure and it cannot be burnt in a single plane. So by doing X technique, we could burn the whole area in a single plane. So that was an advantage, we got it, and that idea we now have been using it. So this is how this patient fared. There were 166 lesions, and then we use a temperature, that is, we have a special probe and generator where we use 75 degrees to burn for 60 seconds. That is a protocol. And each lesion is placed around 5 millimeters separate. So that is how we overlap one burn with the other burn, because there is an overlap of 3 mm. So that is how we take it apart. So this is a brief video which I would like to play, which we have published already in the literature. So this is how it is done. This is a robot we have in our department. This is probably there are only 2 places in India we have robot. One is here and the other one is Amrita. So this is a robot where we have already planned, as I showed. And once the planning is done, the patient is fixed with a frame under general anesthesia, and then we put this trajectory. The trajectories are all pre-marked. There is a registration which happens with the robot. It registers completely based on the MRI and the CT. And then it gives us the trajectory. The moment we go a command for a particular trajectory, the robot actually steps in for that trajectory, and then the length is all given. It's all pre-fed, and we know what to be done. Here we are actually, we have drilled it, a small hole which is around 2.2 millimeters. And this is a coagulation probe. Sorry. Okay. Yeah. So this is we drilled. After this is we are coagulating with the monopolar, because the drilling happens till the inner table, and then the dura is intact. To burn the dura, we just do the coagulation process. And once the coagulation done, as it is shown here, the distance is given. After that, we put this RF probe inside the hole which we have drilled. So the desired length probe is inserted inside. Once that is done, we fix it, and then this is a pulse generator where we use 75 degrees centigrade for 60 seconds. That is how we produce a burn, and then we keep withdrawing the catheter up so that we keep burning. This is before burning, we do a intraoperative CT scan which we have in our department, and then we see the preoperative trajectory merged with the intraoperative CT. You can see this green line and then the actual probe, which are exactly and perfectly matching. Once we are sure about that, we go ahead and do the lesioning. So this is how we merge. You can see it's a bullseye. So this green dot is inside the probe, actual probe. This green one is a preoperative MRI. The steel which is seen is basically the intraoperative CT. So once we are sure about the positioning, we perform this lesioning. You can see here. So this is how the lesion is performed. And once the trajectory is complete, we just withdraw and then put glue inside so as to prevent CSF leak, because as I told, CSF leak would lead to brain shift, and which can cause derangement in our calculations. And that is how this is the final thing. So this is the final post-operative CT. So you can see here a nice, beautiful disconnection. This whole hemisphere, as I told, is disconnected starting from the frontal, middle, posterior, as well as the corpus callosum, which cannot be seen here, which would be better in an MRI. So this is how the line of disconnection is. So post-operatively, this patient, this was because we have done around 11 patients till now, and one of the rare complications, which usually happens with open hemispherotomies, in this patient, because we don't know, as this has been a new procedure, patient developed hydrocephalus. So we had to shunt this patient because of the dip in the sensorium. Once the VP shunt was done, patient improved significantly and then was discharged in a great condition. Pre-operatively, this patient had a power of 4/5, but post-operatively there was deterioration, which is as expected because once you do a hemispheric disconnection, patient becomes hemiplegic. In this patient as well, there was a power of 2/5, which was around 4/5 in the pre-operative period. This is a video which is 6 months after surgery, and you can see in the OPD. So she is able to lift the upper limb as well, and the lower limb better than what it was in the immediate post-operative period. So this was a video at 6 months, and we got a video recently, home video. This is a very latest video, which she is able to walk with support. So that's a great thing, and patient is moving around with at least she's moving around, although with support. That has been an advantage. So rest of the indications for general hemispherotomy, I would like Dr. Ravi to have.
What are the indications of hemispherotomy? These lesions with unilateral hemispheric involvement such as Asmussen's encephalitis, hemianencephaly, post-infarct epilepsy, hemisphere FCD, and less commonly Schulz-Weber's syndrome. And the absolute contraindications are the presence of bilateral independent spice. It remains as an unfavorable prognostic factor. What are the, in this we have 4 types of techniques. One is vertical parasitical. It is described by Edelandi, and peri-insular technique. It is described by Elmore, and third one is endoscopy assisted interhemisphere transalosal hemispherotomy. It is done by Chandra sir. And fourth one is Raj. It is done by Chandra sir. These patients, and we have done a total of 27 open hemispherotomies are done till to date, and 19 were vertical parasital, and in 8 we have done peri-insular hemispherotomy, and the mean follow-up is 40 months. In this patient, 20 out of 27 patients are as 1 and as 2, and outcomes of patients in endoscopy hemispherotomies. In this, to date we have done 55 hemispherotomies, and these patients in this 80 patients had as 1 and as 2 outcomes, and in two patients we had done repeat surgeries, and these patients have 90% are seizure free. In outcomes of Raj, till date we have operated of 11 patients, and all these patients have as 1 outcomes, with only 2 patients we had as 2, and main follow-up for the patients is 20 months. In patient 5 and patient 2 we have done surgery, and 9 out of 7 patients are seizure free on last follow-up. These are publication in JNS Pediatrics.
Thank you, Ravi. I thought I should just give you a small introduction to what is this technique. So we also developed the endoscopic technique And that was, quite unimaginable, because how can you disconnect a whole hemisphere through a small opening? And when we thought about it, it was as difficult or as easy as trying to pass a camel from the eye of the needle. But we did a lot of cadaveric studies. These are the indications. So one should know that hemispherotomy is a generic surgery. It could be very straightforward, as it is in this case of post-infarct, where you have a lot of porencephaly, or it could be extremely complex, like in hemimegalencephaly, where you have solid parenchyma. And we started hemispherotomies in 2002. It's about 20 years now. Then we went to interhemispheric. So you can see the line of disconnection. This is how we would do following. And then using that, we developed the endoscopic technique. And in endoscopic technique, we used to use a small opening of 3 into 4 centimeters. And this shows the technique. And these are the papers we published in endoscopic. And once we did it, there were several centers across the world which took this up. And it has also come in various textbooks, including Professor Jerome Sengel textbook of epilepsy, which is considered as the Bible for epilepsy for everybody. And here you can see how, using endoscopic technique, we produce this beautiful disconnection. And this is a patient which I operated in Malaysia. It's a most complex case, hemimegalencephaly with aplasia of the frontal horn. And patient lost only 40 cc of blood and was seizure free. That's the child. So definitely endoscopic reduce the blood loss post-op stay. But you can see it's highly technical. One needs to be an expert with endoscopy. It cannot be done by everybody. And plus there is still, it's invasive. You have to make an opening. There is blood loss. There could be issues of complications. The opening could be small, but if you tear a blood vessel inside, again, there could be hematoma. And in hemispherotomy, you have to really go inside and then disconnect the whole hemisphere. So that's a very, very radical surgery. So that's when we developed this robotic technique, and this came out in the cover page of JNS Pediatrics, because it was done for the first time. And before we started, we of course took the ethics committee clearance, because radiofrequency ablation has been done in thousands of cases across the world. So we were able to convince our ethics committee that we could do it for hemispheric disconnection. And we got this idea when we were treating this large hypothalamic hematoma. So when we were disconnecting this here, I just realized maybe we could just go laterally and then we produce a hemispheric disconnection. And this was possible because we had a robotic system, so you can plan multiple trajectories in a very short period of time. We had an O-arm which could do an intraop CT, and then we had a very nice radiofrequency ablator. And then when we calculated, we found out that approximately with 100 to 120 burns and 7 to 10 trajectories, we can produce a hemispheric disconnection. And recently we got this Cosman generator which can produce 10 millimeters of burn. So this shows few cases. So you can see the nice disconnection here. And this patient was having about 20 to 30 seizures a day. Was seizure free. Now this is the X technique what I was talking about. So using this X technique, we were able to create a very nice planar disconnection. And again, you can see it's such a nice discretion on all this without a loss of even single drop of blood. Another patient was 5 months old. So this is immediately after surgery. You can see sutures. And once the sutures were removed, he went back to the general practitioner, and the GP was not able to understand what surgery was done, because there was no scar over them. They could not even make out any scar on the head. Few more examples. Again, post meningitic, we produced a nice hemispheric disconnection here. That's a child, seizure free. Another Rasmussen's, again having several seizures, say that's a post-op day 3. Again, you can find a very nice hemispheric disconnection.
Left hand upar utao.
Another patient, again post-stroke. Again, this is the same patient what we showed here. So definitely it's an evolving technique. One of the biggest shortcomings is the long duration it takes. 100 burns takes 8 to 9 hours. But the bottom line is, at the end of the day, you have the satisfaction that you don't lose a single drop of blood. I think that is revolutionary. You have a surgical technique where you're doing a complete hemispheric disconnection without losing a single drop of blood. And the patients, they recover amazingly. When we do the fever charting, even with endoscopic, they keep on having fevers till 8th day, 9th day, because the blood goes into the ventricle. But here, next day itself, the patient opens the eyes, is completely, as soon as the surgery is over, it doesn't even require elective ventilation. So all the hemispherotomies, they require overnight elective ventilation. So patient opens the eyes immediately, is talking to you, is completely conscious, because it's a very minimally invasive, I think the most minimally invasive surgery anywhere for neurosurgery. So we called it as ROCH, stands for Robotic Thermogulative Hemispherotomy. ROCH also stands for the small and gentle bird from Arctic. And I think it gels very well with the technique. You know, it's small, it's very soft on kids, no hypothermia, and ideally done in kids because that is where we require to do hemispherotomies. And for me professionally, I think it's been a for all of us, it's been a huge journey because I come from an era where we would see the whole hemisphere removed. So we started with a hole in the brain to evolve to something like a line in the brain, which is most minimal. So it does look very promising. And of course, I have to thank all the members of the epilepsy surgery team, without whom this wouldn't have been possible. So Dr. Manjari, Dr. Ramesh, especially here, all my fellows, thank you very much.